Welcome to the License to Lead podcast. I'm Patty Fay. This podcast is for physicians or anyone who thinks healthcare needs a transformation led by physicians. License to Lead means that physicians are charged with and must be in charge of guiding the vision, the standards, and the culture of healthcare systems. If you want to join in the conversation or learn more about activating physician leadership, go to license2leadpodcast.com, where you can send me an email or even leave me a voice message. I'd love to hear from you. Hello, everyone. Welcome to the License to Lead podcast. I'm Patty Fay. Today, I'm talking with Dr. Patty Gabow, one of the most successful healthcare leaders in the United States. Dr. Gabow is a nephrologist, a researcher, a professor, a prolific author, and most notably, she served as CEO of the Denver Health and Hospital Authority for 20 years. Now, you'll note that when I said she's one of the most successful healthcare leaders in the U.S., I didn't qualify that by saying one of the most successful female leaders or one of the most successful physician leaders. So she has received prestigious awards galore from U.S. associations like the National Committee on Quality Assurance, the Association of American Medical Colleges, the AMA. Her alma mater, UPenn, recognized her with their Distinguished Graduate Award, as well they should have, in all the ways that matter in healthcare. And consistently for 20 years, Dr. Gabow had outstanding results in what's a very challenging environment. She had excellent patient outcomes, engaged doctors, nurses, and other staff, and remarkable business results. Dr. Gabow ran the healthcare equivalent of a Southwest Airlines. She kept Denver Health in the black for 20 years. Patty, welcome to the podcast.
Well, thank you for having me. I've listened to a number of your podcasts, and I can say we're twins in our opinions, not just our name.
We are totally of like mind, Patty. So let's get this conversation started.
Well, I have this chronic voice problem, spastic dysphonia, and I usually tell people at the beginning of something that I have this voice problem and the treatment is Botox, which does nothing for my wrinkles, but I hope I have beautiful vocal cords. But I also say this was probably God's answer to my talking too much.
So, Patty, can you get us started a little bit by talking about Denver Health and what the institution is all about and your role there?
Yes. Well, I love Denver Health. Let me start with that. And let me say it's been a pillar of the community since Denver was 1 year old. When Denver was a 1-year-old mining camp, 2 politicians got in a fight and one shot the other. And the community, then a mining town, said, we need health care. And that was our beginning. And it grew up from that in a variety of ways. And I would say that the brilliance of the city mothers and fathers over more than 150 years was whenever anything became a component of healthcare, it was added to Denver Health. So they developed well ahead of anybody else's vision an integrated delivery system. So when I took over, Denver Health was the model integrated delivery system for the country. So we had the hospital, which was a level 1 trauma center. We had all the neighborhood health clinics in Denver, and that's very unusual. Community health centers and hospitals just have always sort of gone their separate ways. But in Denver, they were one. We had the paramedics, again, very unusual to have the 911 emergency system with the paramedics part of the system. We had a 100-bed non-medical detox unit. We ran our own HMO. So we link the financial system with the delivery model. All the school-based clinics in Denver were part of Denver Health. We did the healthcare at the jail system. So that was a part of us as well. And so this was really unique. And recently I published a paper with someone from Alameda County showing that all the things which were combined in Denver Health were in like 25 different organizations in Alameda County. And that made for duplication of administrative structures, duplication of fundraising, but more importantly, it didn't give seamless care for the patients. So in Denver, if you were a student at one of the school-based clinics and you needed specialty care, easy flow. If you were a prisoner being discharged from the county jail and you needed ongoing care, seamless flow. If you were at a community health center and they diagnosed diabetic retinopathy or cancer, most community health centers, you couldn't see a specialist. Flow right into Denver Health. And it was linked by a single leadership team, single pharmacy, single laboratory, single radiology. It was absolutely wonderful. And as I used to tell our people, a model for the nation. And many leaders from across the United States, including political leaders, came to see Denver Health, and they all couldn't believe it.
It sounds like Denver Health was just a perfect fit for you and the work that you do and the environment that you love. Early on, did it ever occur to you that you'd be there your entire career?
No. In fact, I distinctly remember meeting the head of GI, Jack Schaefer, my first day. And he said he'd been at Denver Health for 10 years. And I came home and said to my husband, can you believe there are people who stay at one place for 10 year?s? And when I left, I'd been there 40 years. So no, I didn't. But it is certainly while I was there and all the time in its history, it was a place that totally aligned with my values. Mm-hmm. And that is so absolutely critical. I really believe one of the big issues with burnout these days is that we are finding ourselves as physicians often in an ethical dilemma with the institution's goals and aims and behaviors. And I think those ethical dilemmas really create moral injury in us, and that leads to burnout. And I think when you're looking for a job, the most important thing is to be clear what your values are, be clear what the institution's values are, and make sure you're aligned. I would never have had the career I had if I was not at a safety net where my values aligned.
Yeah. The idea of the ethical conflict that physicians get into, what do you attribute that to? Can you identify some examples?
I'll approach that two ways. The first is, I don't think a lot of places, institutions, are very clear about their ethical principles. And when I became a leader at Denver Health, we had a meeting with all the physicians and an ethicist, and we said, what should be the ethical principle that drives Denver Health? So first of all, we asked the question, which I would say most institutions don't ask, and certainly the answer is not their tagline. I mean, let's be clear about that. And we said, well, as a healthcare institution, there are sort of two acceptable ethical principles. What is the most good for the most people? and the other is the most good for the sickest. And I would say most tertiary care institutions would say it's the most good for the sickest.
Mm-hmm.
We said, as a safety net, it's the most good for the most people. And we followed that. I use that in my decision making, and I'll give you an example. We were the last major health system to get an MRI. And the docs were all saying, we need an MRI, we need an MRI. And we didn't have much money as a safety net. So often I found myself in a position of having to make a decision between two good things, not between a good thing and a bad thing. And the other thing we wanted to do that year was open school-based clinics in every school in Montbello. And we said, well, our ethical principle is the most good for the most people. So that's school-based clinics in Montbello. And that's what we did. And people, I find people are okay with you making tough decisions if there's clarity about what are your rules for making those decisions.
Right.
I also have to say that most institutions are very profit driven right now. And I find it hard to understand how you can have the core principle of always putting the patient ahead of your own values. And that means as a person and as an institution, how that works when you're so driven by profit. And at Denver Health, that wasn't the case.
Mm-hmm. So everything was looking good and running perfectly when you got into a leadership position?
No.
So tell us that. How did that happen? How many years were you with the organization and in what role? And then how is it that you ended up as the CEO?
I always joke by saying if you stay around long enough, they make you head. But so I started out running the renal division. Then I became chief of medicine. Then I became what then was called deputy manager of medical affairs, which was really like the chief medical officer. Then I became CoCEO and then CEO. And so that was my journey. And
I haven't heard of a co-CEO before exactly, or at least not one that worked. What was that about?
Well, that was about the person who had been CEO being terminated, and they wanted someone else, and I had been chief medical officer. But at the time, there was the belief that doctors couldn't do finance. And Denver Health had major financial issues, like a $39 million shortfall. And it was like, well, we better bring in a finance person. So they brought a finance person from the city, Tom Moe. We were part of the city government still at that time. And we became co-CEOs with the idea that he'd do the finance and I'd do all the healthcare stuff. And he retired fairly shortly after that. And Wellington Webb became mayor. And he said,
"Take it away, Patty.
Go for it." And that was a great vote of confidence. And
how did your financial acumen stack up?
Well, let me just say, over the next 20 years, we were in the black every single year, despite the fact that our uninsured care went from 150 million to 420 million, and our city contribution stayed the same at 27 million for our uninsured care.
Wow.
And so I would say that stacks up pretty well.
And you started at a $39 million shortfall?
Well, that was when Tom Moe and I both took over. But Denver Health had always had issues with finances. It was an ongoing struggle.
But you turned that around. I mean, you were in the black then for 20 years. What do you attribute that to? I know that might be a big question, huh?
That's a big question. Well, for one thing, I think taking advantage of the integrated model of care, which I really believe a lot of what we talk about today as integrated healthcare is really not integrated. But the way we did it at Denver Health was really integrated and seamless. I think also getting rid of waste. There, even at a safety net, there's waste. And we adopted Lean, our Toyota production system, at our organization. And we realized over $190 million of hard financial benefit over the 7 years that I was there, and we were doing Lean over that period of time. And that was important. I think the idea of aligning the delivery model with the financial model. So we were the first Medicaid HMO in the state, and Medicaid was our core business. And I believe in HMOs if they're done with the patient at the center. And that was very good for us. And then I always used to say there wasn't a federal dollar I didn't love. And
you went
so
after it.
The benefit of an integrated model is it didn't matter what the feds were calling money this year, AIDS relief, school-based clinics, community health centers, public health. Oh, I forgot to mention we were also the public health department for the city and county of Denver in this integrated model. So I think all those things were important.
You would have started Lean maybe 2005 in that range?
Yeah, in that range, 2005, 2006.
So you would have had more than a decade where you were running in the black before you started Lean. So other stuff going on then, other than those efficiencies. And can you talk about the contribution from the organizational culture that you established?
Yes, and there's one other thing I should have mentioned that, as you correctly pointed out, some of the positivity started before Lean, and that was due to our becoming an independent governmental entity and getting out of the city.
Ooh, say more.
And imagine going to a mayor and saying, I've been thinking that your second biggest department of city government would be better off away from you.
Ouch. Mm-hmm.
They usually don't say, wow, that's a great idea.
Yeah.
How did you come up with it?
Mm-hmm. So how did you know that you needed to do that? What happened that made that so clear to you?
Oh, there were a long litany of things that were pretty clear that government is not designed to run healthcare, which requires a lot of innovation and flexibility. I think government should pay for healthcare. I do not believe it should run it. And I'll give you an example. When the first Gulf War started, there were a lot of nurse anesthetists who were in the reserve. Many of them were called up, and every hospital in Denver immediately raised their rates for the CRNAs. We had to go through the city personnel system. By the time we got through it, the war was over. Now, it was a short war, and everybody else was dropping their rates then when we were raising ours. Also, when we went through a period that hiring nurses were tough, we wanted to give the night shift nurses free parking. You couldn't do that unless you gave free parking to every city employee. So I could go on. There were thousands of reasons.
Mm-hmm.
And I told the mayor we could either maintain our mission through getting increased flexibility, or we could stay inflexible and lose our mission. Mm-hmm. And he was courageous and opted for letting us become independent.
Was he instantaneously courageous, or did it take a little encouragement on your part?
4 years.
Oh, really?
At one point, he said to me, Patty, are you ever going to get off this issue? And I said, yes, as soon as you say yes.
Wow. So that must have been a huge deal, Patty, to kind of unwind from the city. Before you got into the CEO role, did you already have a sense that this was a problem that you needed to detach from the city, or was it something that you saw once you got into the CEO role?
Well, I got into trouble very early with the city processes.
Oh, geez.
When I was a relatively new chief of medicine, I was trying to recruit a chief of cardiology. And he needed a $50,000 piece of equipment to come. And I talked the chief of medicine at the university into giving $25,000. And I had saved $25,000 in my budget. But in those days, everything, don't fall off your chair, but everything above $500 had to go to city council.
Oh, my.
And if Denver Health had any extra money, there was a strong sucking sound of it going back to the city. So I knew there was no way I was going to get this $50,000 piece of equipment through city processes. So I called the company and explained my situation and said, could you please do it in $495 increments? So this piece of equipment arrived at the loading dock with 100+ pages of invoices for one piece of equipment.
That is hilarious.
So it didn't take long for the deputy manager of Denver Health, John Zabarbro, to figure this out. And he called me and said, I'm coming up and breaking both your kneecaps.
Oh, geez.
And I should have stopped there. But, I always had this part of me that couldn't resist. And I said, oh, John, you're just mad because I outsmarted you. That wasn't good. I thought I was going to have the shortest tenure of any chief of medicine in history. But we became great friends. And he had to go to city council and explain how I was a novice and brand new and didn't understand. And mea culpa. But I got the piece of equipment and I got my cardiologist.
Oh, wow. And you got a clear understanding that it was a lot of bureaucracy to stay with the city.
You got it.
Mm-hmm. So then you had to spend 4 years detaching from being part of the city. And then what?
Just wonderfulness.
Really?
In all seriousness, Denver Health is a wonderful place. And the people there it doesn't matter whether you were a groundskeeper or a painter or a clerk or a director of service. People were committed to the mission. I told them, look, we can be a model for the nation. And when you tell people at a safety net in the middle of the country, you're going to be better than Mass General, that's giving them real inspiration to do what has to be done. And we were better. Right before I left, there was a group called the University Health System Consortium that had all the academic health centers in the nation. And we had the lowest observed to expected mortality of all the academic health centers in the United States. And that's with 70% of our patients being minorities, 30% not speaking English, many homeless, and yet we were doing better than what people thought were the best places. Pretty astounding. 80% of our kids were fully immunized. 70% of our patients had their blood pressure controlled, way above the national average. And we were in the black, and we had the best trauma survival in the United States. So we were delivering extraordinary care to a highly vulnerable population, staying in the black while caring for everyone, and a culture that was positive and believed in the mission, and it was wonderful.
Right. And the cause and effect there is something I'm so fascinated by. So you ushered in, I suspect, a fantastic culture.
I think the culture was there, and I nourished it, and my team nourished it.
Right.
And I would point out my team was mostly women. When I was, during my tenure as CEO, over that tenure, I was the CEO. My chief operating officer was a woman. Mm-hmm. The CFO was a woman. The general counsel was a woman. The head of the health plan was a woman. The head of government relations was a woman. The chief communications officer was a woman. I think in some ways it was a feedback loop. I think, and the men who reported to us said this, that a safety net, which is committed to equality, is open to women in leadership, and women in leadership support the equality and the mission of the safety net. Mm-hmm. So I think that helped.
Yeah. So you had a group of people really committed to creating and then sustaining a really thriving culture, a really engaged group of people. I'd love to dig more into what those elements are, because you were being stacked up against, Mayo Clinic and Cleveland Clinic and the Ivy League academic institutions, and you were comparing favorably to them.
Better, not
right. It's the recruiting, right? It's the recruiting, it's the reward and recognition, it's performance management. Any of those jump out at you as far as things that you took on that really reinforced the excellent culture?
Wouldn't say so much took on as nourished. For example, we had no bonus plans for anybody. Executives, doctors, no one. I dislike bonus plans. I think it creates a moral dilemma. For example, if you're the CEO and you get rewarded for the bottom line, are you going to open your doors to the uninsured, to the immigrants, to the most disenfranchised, to the prisoners? I don't think so. I dislike bonus plans. The other reason I dislike it is, by and large, bonus plans, even if people say they're equitable, the people at the top are getting the most. And you can't be successful if the person who's keeping the grounds is not invested. I mean, it's everybody. It takes the family. And we talked about ourselves as a family. And so that was it. We had no contracts. I would interview doctors who would say, well, where's my contract? And I'd say, there is none. I don't have one. You don't have one. And sometimes people would say, well, how does that work then to protect me? And I said, you don't need protection. You do what's right. Great. We didn't have any special privileges, no special doctor's parking, no doctor's lounge. And I'll give you an example of what that did. I never believed, as I said, in bonuses. But when we put in lean, we asked all the mid-managers to save $30,000 a year. And we trained them in how to see waste and remove it. Some of them were bringing in $300,000, $400,000 in savings. And I said, well, gee whiz, maybe we should reward them a little bit. And I mean a little bit, like, several $100s if you tripled your goal. So after about 6 months, I always met with the lean black belts, and they said, Dr. Gabow, we think you should get rid of that bonus because we think it's inhibiting collaboration. I mean, where else do people say, could you please stop giving us money? I had many executives turn down their raises.
Wow. We know the neuroscience of incentives point to the fact that it actually is a hit to autonomy. So whether it's a carrot or a stick, and an incentive is usually seen as a carrot, but the brain experiences it as diminishing autonomy. So it's coercive. Somebody else has already decided what you need to do and how you need to do it, and then they'll give you your cookie. You get what you incent. It's just that what you're not ever overtly incenting is discretionary effort and collaboration and cooperation. You're incenting specific financial, usually selfish goals. And it's so wrong-headed.
And I think you have to be clear that you have to give people inspiration, and you have to give them positive feedback, but not money. So I wrote many handwritten notes. I also think that's a lost art. But I also would do something. I would draw a star on a piece of paper, no words, and send it to someone for something they did. And you won't believe this, but I would go into offices and see the star pasted on their bulletin board.
I believe that.
And I also believe you have to celebrate. We had a day of celebration every year. That was a big deal. And one of the things we did was we gave out a CEO award or awards, which I told people had no criteria, just whatever I wanted. And, I gave it, one of the ones I gave that I loved was to one of the grounds workers, and he got a standing ovation at the event.
I love that.
You can't buy that. The other thing was lean. Lean is built on respect for people, and it's letting the front lines solve the problem. And we did these rapid improvement events with 8 people who fixed a problem in a week. And I remember when they started, one of the clerks sent out this email. She had been on the team, and she said, "You got to do one of these rapid things. They're terrific." And my last rapid improvement event that I was on before I retired was on surgical scheduling. And the 2 people sitting next to me had high school educations and were clerks. You can't buy what that says to people about your belief in their ability to contribute. And so I think you have to reinforce people, trust them, value them, and that's the way you reward.
Yes. Yeah, absolutely. Here. All those things. That's just such a terrific way to build engagement and get that discretionary effort where you don't even know why things are working so well. In some cases, it's like things are humming because you've got people aligned with their values and people that want the organization to be successful. They're so committed. And how about your approach to bringing people into the organization? How did you get the right people in the door?
I think in many ways the system selected. For example, if you were an executive or a physician who wanted to make a lot of money, you weren't coming to Denver Health. Mm-hmm. But being an academic institution, being able to do research, to teach, to care for patients, to not be driven by money, it was the self-selecting. When people visited us from around the country, they could not believe on the quality of our physicians. They were like, how did you find these people? And they found us. The people who were in medicine for the right reasons found us.
I love that, Patty. Have other institutions been able to emulate what you've done? And do you see it happening in other parts of the country? What's going on with that?
Sadly, I would say the people who came to visit us, from Atlanta, from Texas, from California, the talks I gave to different places around the country, they all said the same thing. This is incredible, but we could never do it. It takes political will. I remember once going to a city I won't mention that I had been to many times, and their community health centers and their safety net hospitals were separate. And I went there many times saying, integrate, come together. But no, they all had to be on their own horse. And at one point I said, look, I don't care if you get married, but could you at least live together? And the political barriers are just hard.
Yeah. You must have had a way to be so influential and inspirational when you were building the systems that you put in place.
Well, first you got to build your team. And as I said, I had a fantastic executive team. I had a fantastic group of physician leaders. And I had a fantastic group of people down to the frontline groundskeeper. I think one thing that is really clear, a leader alone can't do any of this. Doesn't matter if you're charismatic, doesn't matter if you're smart, doesn't matter if you're a doctor or not a doctor. If you don't have the team all the way down to the front lines, you will not succeed.
Right. And it's the CEO that builds the team and finds the team members, right?
To some extent, but the culture of the institution is a magnet to the right people.
Right.
And if the CEO and the executives nurture the culture, then it will be a magnet.
Mm-hmm. You talked about people coming by and just being amazed at the quality of physicians that your safety net institution could attract. I'm interested in hearing more from you about physician leadership and what are the elements of physician leadership that you think make physicians suited to leading?
Well, I think, over centuries, the profession has developed a set of values. And the list is quite long, and I won't go through them all, but I think there are 2 or 3 that are very important. One is putting the patient's interest above your own. That's foundational. The second is integrity. And I think those 2 sort of key values in the hierarchy of values of our profession are one of the things that make physicians good leaders. I always said that training to be a good physician is training to be a good leader. First of all, the commitment to patients. Then I think the ability to discern critical information. When you're taking care of patients, you're getting information from everywhere, and you have to be able to decide what's critical. The same is true when you're running an organization or in even if you're not the CEO, in any leadership position, you're going to get a lot of data, and you have to be able to decide what's critical. You can't deal with everything. I think the other thing is to be clear-headed in a crisis. We go to a cardiac arrest, we don't decompensate. And you can't decompensate when they call you and say, we have opposing gang members in the ED, or the whole IT system has just gone down, or we have a case of Ebola. You can't lose it. I think the other thing we've learned in our career is when you don't know the answer, consult someone else. If you're taking care of a patient and you need an ID consult, you're willing to get one. And I think the same is true in leadership. There's no way you'll know every answer to every question. You have to be able to feel quite comfortable lifting up the phone and calling someone, or Zooming as it is today. I think the other thing that we learn as physicians is making decisions with incomplete data. When was the last time a doctor had all the data they wanted to make a decision? Like never. Mm-hmm. And the same is true in leadership. If you wait to make a decision until you have every relevant piece of data, you will never make a decision. It just doesn't happen. And I think our structured approach that we've learned in approaching a patient, first you gather the data, then you make a diagnosis, then you develop a treatment plan, then you monitor the treatment plan. If it's not going like you think, you either change the diagnosis or change the treatment. And I always say that's how I manage leadership problems. And a lot of times people who aren't trained as clinicians don't make a diagnosis of the root cause. They treat a symptom. For example, you have a problem in the OR with not enough ORs. So they build more ORs when the problem is flow, so
yep.
You got to make a diagnosis, not
Right.
a symptom. And I think we're good at that as physicians.
I talk about the tacit knowledge that physicians have from coming up through the ranks and really being involved in everything from, drawing blood, doing EKGs, working in the lab, working in the outpatient department, even learning how to manage relationships with very difficult personalities sometimes. And what role do you see for that tacit knowledge? Do you buy into that idea that knowledge gained helps you make decisions?
Well, absolutely, because what we've lost, I believe, in healthcare is the understanding that this is about taking care of patients. That's why we exist. And I think the one challenge for physicians often may be that we're used to dealing with the patient in front of us. But once you become a leader, you have to make that jump from the patient in front of you to the population you're responsible for. And that is a jump. But I think keeping the bedrock that it's the same issues, just now at a different level. And so, yeah, I agree with you. And what often administrators lack are those things. They've never been at the bedside of someone who's dying. They've never been in a clinic where someone can't afford their medicine that they need to stay well. They've never seen suffering up close and personal. And I used to tell the residents, I always met, when I was chief of medicine, I always did new orientation with the residents and the medical students. And I used to tell them, you have a tremendous opportunity here at Denver Health to see the other America firsthand that leaders in other industries never see. A banker doesn't see this. An architect doesn't see this. You get to see it. And then what has to happen is you have to decide what that means to you in your life. And so I think it is, particularly in a safety net, seeing up close and personal what it's like to be ill in this country.
Mm-hmm. Yeah.
And that's what we're about.
Mm-hmm. Absolutely. Mm-hmm. What do you make of the fact that for some reason in the profession of medicine, as opposed to other professions, we only lead about 5% of hospitals and healthcare systems. Physicians only lead about 5%, and business-trained folks come in and lead the other 95% or so. What do you make of that?
I don't think it's good. That's what I make of it. I also have had discussions with people at business schools, a number of them, saying, why do you think that there is so much training in healthcare administration or MBA for physicians who want to go into leadership, but where's the clinical training for administrators who want to go into leadership? And one of them from a very prestigious school, which I won't name, said, well, administrators pick that up. And I said, well, so I can't pick up how to read a balance sheet, but someone can pick up what it means to care for someone who's sick. I don't get it. And in the book I just wrote, I have a whole list of things administrators should do in the absence of formal training to be able to really get a sense of what is this that we're doing in healthcare.
Right.
It's not an industry. We don't have customers. This is not transactional.
We have that fiduciary responsibility, which is what you referred to, meaning that we are obliged to put the needs of the patient in front of us ahead of ourselves. Yeah. So did you consider getting an MBA?
No.
Yeah. Do you recommend that physician leaders, up-and-comers, get an MBA?
You know, the problem is it's currency in the current marketplace. I think what's important for up-and-comers is, as physicians, to value their clinical training, to understand what that is applicable to leadership. The list I just went through with you. Second is, a lot of times they're uncomfortable with the financial part. So if they need training in that, get some training. I don't think you need an MBA to read a balance sheet or to understand cash flow or prioritizing capital. But I do think that it does give people some confidence, particularly women who may not have confidence in the first place about leadership, to get some training around where they feel their areas of weakness may be. But also, I think you have to say to yourself, here are the things I need. Where can I get that most efficiently? Efficiently, both in terms of time and money. I don't see it as something that's necessary or even sufficient if you get it. But if you feel you need something, it's like anything else in life. If you feel there's a gap to your being successful, then fill the gap.
Yeah. Yes. I was taking on a role as Associate Medical Director of Human Resources at Kaiser Permanente, and I'd had a lot of interest in organizational culture and engagement and leadership and performance management. And I went out, when I was offered this role, I went out to Stanford for a 1-week executive HR course. And I think that's the kind of focus. I mean, then I had some resources, some understanding, some connections. And of course, I was paying attention to exactly what I needed to pay attention to during that course because I knew what I wanted to learn. And I think that's to your point about what's the most efficient, focused way that you can get the education that you need wherever you feel a gap. You mentioned especially women who may lack confidence. And I think that's a fantastic segue to more specifically talk about your book. And we have been talking about your book because while it's titled Times Now for Women Healthcare Leaders, it's really chock full of information about organizational culture and engagement and especially leadership. But your intention here, it looks like, was to focus specifically on women. So maybe just talk about what inspired you to write this particular book.
I would say 3 things. Well, maybe 4. I like to write. If I hated writing, I wouldn't be writing a book, but I like to write. But specifically this book, 1, I think healthcare is a mess right now in America. I mean, we spend twice as much as every other developed country. We get poorer outcomes on a whole range of things, from maternal mortality to life expectancy to admission for ambulatory sensitive conditions, go down the list. And while I don't blame men for this, it is true, it is a fact that the system has been designed by men, and largely white men, and at all levels, from government to healthcare institutions, to insurance companies, to pharma, to device manufacturers. So, and I believe if you keep the same people at the table, you get the same results. So we need different people at the table. We need women and men. We need white people and people of color. We need young people and old people. And hopefully, if you get diversity at all those tables, you get a different outcome. That's one reason. The second reason is fairness. We make up 50% of the population actually 51%, and 80% of the healthcare workforce. And yet we're about 10 to 13% of the leaders, whether you look at deans in academic medicine or you look at CEOs. Well, that's not right. That's not fair. And we have a lot to contribute. We have seen healthcare from a different perspective. We're the caregivers, by and large. We're the mothers. That's a reality. And we care for our parents primarily. It's women who are the primary caregivers for parents, for children, and we're not at the table. I mean, you know, when the Republicans in this Congress were looking at redoing the ACA, there were no women in that group.
Really?
None. So fairness, the healthcare system is a mess. And finally, I wanted to pay forward what I'd learned. You know, I'd been doing this for 40 years, and I had great mentors for me, great sponsors for me, great people who inspired me and helped me. And I wanted to do the same. And, you know, there are only a limited number of people you can mentor one-on-one. But hopefully if you write a book and people read it, that you can mentor many more.
You know, also women appear to have better outcomes, whether it's one-on-one with patients or when women are present at the head of organizations, on boards, in the C-suite. We even see this with COVID, right? The states that have female governors, the countries that have female leaders seem to be managing the COVID crisis better. Can you address that at all?
Well, Melinda Gates has a book out called Lift, and I think the subtitle is something like Empowering Women and Improving the World or something like that.
Right.
When I say women have something to bring to the table, it's not just their perspective as caregivers, which is critically important, but they have unique skills. And studies that have been done on this show they're motivated by integrity. They're motivated by wanting to do good. They're motivated in a belief that they can bring change that makes things better. And I think what we're seeing right now is kind of a tipping point of that realization. For example, Goldman Sachs ran an ad, a full-page ad in the New York Times a couple of years ago that said, "What changes when women lead business?" Everything. I think we know there's very good data that when women are in leadership, whether it's CEO or CFOs, that the financial outcome is better. We don't need more money in healthcare, but I think that's one example, the financial benefit. I think what we're seeing with women in politics is when women are in political positions, whether it's state legislatures, city councils, Congress, that the attention to healthcare and core things that support families are much more likely to happen. And as you pointed out, there's a growing body of data that on an individual patient level, women have better communication, have more attention to preventative care, and may even have better outcomes regarding mortality. So what we don't know is when they assume a CEO position, does that transfer from an individual patient to a population? There just aren't enough women CEOs of healthcare to address that question. But I would say, why not? Why wouldn't it translate?
Right. Yeah. Yeah, I'd agree. Seems like that performance will translate to the performance of female CEOs as well. So, Patty, your family has been a real source of inspiration for you. And I wonder if you would talk a little bit about the impact of your family on your career and your career satisfaction.
Well, I'd actually like to read, if it's okay with you, the dedication of the book, which probably says a lot about my family. To the generations of women in my family, my great-grandmother, great-aunt, grandmother, mother, and daughter, for their strength, resilience, great kindness, and inspiration.
I love that.
My family was really important. My grandfather was really an important person in my life. And, one piece of advice I'd give anybody is pick the right husband.
Say more. This is Hal.
This is Hal, and he's a keeper. Next year we'll be married 50 years. And I always say I had one institution and one husband. And I have two great children, and they have two great spouses. And I had great parents. My stepfather was great. But my grandfather was a huge influence on my life. He had an old Italian saying for every event in life, which he gave in Italian, and my grandmother translated to English. But and I had all his old sayings on the wall in my office with a picture.
Oh.
And one that I used all the time when people didn't want to do something was, if you have a gift and you don't use it, no confessor on earth can absolve you. That says a lot from an Italian Catholic man. All sins are forgivable, but not using your gifts.
Yeah, putting it under the bushel basket, right? What would be one or two words you would use to describe Hal?
Authentic to the core and good to the bone. He's just a good, kind, smart, loving person. And he's supported me always.
Fantastic. Wow. We referred a little bit earlier to the COVID pandemic, and can you talk a little bit about what your life is like during the pandemic that we're going through? Here it is, August of 2020.
My life is not much different. I'm one of the people who are blessed that I have a home. I'm not worried about food on my table. I haven't been ill, and I do what I always do. I write, I prepare talks, I read, I take a walk every day, I spend time with my dear husband, I talk to my daughter every day, I talk to my son very frequently. So for me, it's not been a terrible hardship. I feel very, very sad for the people who are enduring great hardship during this time.
Yeah, it has really been astounding, hasn't it? I mean, really astounding. I have one last question for you. What do you want to accomplish next?
Well, I guess I'd like to continue to be a voice for those who need a voice.
Mm-hmm. Perfect. Well, thank you so much for being on the License to Lead podcast. I have had such a blast talking with you.
I've enjoyed every minute.
Great. Take care.
Stay well and continue to do good.
To learn more about how we work with physicians and other leaders to create healthy work cultures, or to join in the conversation for future podcasts, go to license2leadpodcast.com, where you can send me an email or leave me a voice message.